Bonjour.
Hello, ladies and gentlemen, and thank you for attending this 34th edition of the Rencontres économiques d'Aix-en-Provence that are called allowing for fair access to care. So I would like to introduce the speakers for this roundtable. I'm going to start with Pierre-Yves Joffard. You're a professor of economics and a researcher at the Cercle and member of the Cercle économistes. You're a specialist of anything that is linked to economy and health. Next to you, Florence LUSTMAN. You're the president of France Assureurs. This is a federation that regroups all the companies that do insurance for healthcare payments and payment bills, and you can insure anyone from architects to companies like AXA or Allianz. Next to you, Etienne TICHIT, you are the general director of Novo Nordisk in France. Novo Nordisk is a pharmaceutical lab from Danish origin. It's usually one of the major players in the world on this sector with 40 billion turnover last year. Your favorite, your most popular drug is for people who are obese, and it's available in France for the last few months. Or VANDINE, you're Secretary of State for the Ministry of Health at Cambodia. You started your career as a nurse before you became a doctor, and you completed your training at the University of Yale in the USA. You've just published a book telling your fight against COVID. The vaccination plan in Cambodia was qualified as an impressive success by the WHO, despite the difficulty to access very far in areas in the country. And then Hadja Idrissa, you are the president of the NGO from Guinea, where you're from. Impact Jeunesse is the name of your NGO. And you live between France, Guinea, and Belgium, and you're aiming at improving the access to education and healthcare to this African youth that you became the ambassador today. Before we hear you out on those questions of fairness in terms of health, I give the floor to Pierre-Yves Joffard for a quick introduction. Thank you. Thank you very much to all of you for being here. I have a tough competition as an economist. I like competition, but sometimes it's hard to compete. We're going to try to talk with a very interesting topic. So thank you for choosing this session. We're going to talk about fairness in the access to healthcare. What does it mean? It means that each person who needs care and for whom medicine exists, they can have access to that. And it remains a challenge. It is a challenge in each country, each and every country, and at the international level. At the level of each country, what could come up as a problem? The first one could be the financial cost of the medicine. In many countries, it's patients who pay for the medicine, and for some patients who are less wealthy, it could present in itself a difficulty to have access to healthcare. Second reason that could be detrimental is the distance that you have between getting to care. So even in rich countries, even if with privileged populations, there's some medical deserts, some places where it's difficult to find an appointment with a professional of the health sector. And it's nothing to do with money, but it's for another reason. Then there's a third reason that we tend to overlook. It's the social inequalities and sometimes the cultural barriers in access to healthcare. Some populations, for example, can express or feel that there's disconnected culturally, and it's not necessarily easy. It could be some for linguistic issues, and there are many studies that show that sometimes it's also a question of confidence in the healthcare system. For many populations that are culturally, sociologically far away from the healthcare system, the trust in the healthcare system is not at all given, and it could be coming across as a barrier. This element is particularly important when you think about prevention. For example, social inequalities in health are everywhere in the world, and they're very present in the access to care. But if we go back to a country like France, the financial barriers are limited, but to have access to prevention, we see some very strong social inequalities. And there's a paradox here because the politicians of public policy, they often the policies are often more effective with the most privileged populations who have a higher economic and background, and who also have more education. Unfortunately, it can also reinforce the inequalities there. So this paradox is found at the national level, is amplified at the international level, because the differences between the income is larger, and we have strong inequalities within each country, and we should not forget that. Even in countries of development that is less than France or other Western countries, we have population that can afford medicine, but some that can't. So we have very big inequalities. Sometimes history as well weighs in the choice. Some countries have been submitted to war or natural hazards, and it has affected the healthcare infrastructure. In some countries, with the higher or lower wage level, it's also about having access to the latest medicine, to the latest treatments, and we've seen that historically in the last 40 years in access for the HIV treatment. Some questions, these drugs were developed, but they were not necessarily accessible in as quickly as they should have been in some countries who needed it the most. So this issue is coming up again on the agenda, with the strong drop of the subsidies from the US to some programs that we know saved many lives. I remind you that there's an article, a recent article in the Lancet, that evaluates the cost of the stop of the USAID by the Trump administration to 14 million lives. So the fact that this program has been stopped by the Trump administration has been evaluated by researchers that it's going to cause 14 million people dying in the world. That's what it's about as well when we're talking about access to innovation and to the cost of new drugs. Of course, when we talk about the set of countries in the world and we talk about the healthcare infrastructure, sometimes we see some healthcare systems for primary care or first aid that some of those centers are hard to maintain as well throughout the whole territory. So there's some differences even within the same country. So there are many questions to discuss. We're going to try to discuss as many as we can. We have a very rich panel, very diversified panel. So we're going to try to use this diversity to produce at least some interesting questions and hopefully some answers. Thank you, Pierre-Yves. Florence LUSTMAN, we're going to start this roundtable. I'd like to know your feeling about the access to care in France. In the white book that was prepared before the presidential election, the part that people still have to pay for the medicine was one of the best in the world. Only 7% is the share that they have to pay. But this number is probably masking some difficulties of access to medicine for many of our citizens. Can you tell us exactly who and what role can an insurer play to make sure to mitigate that? Hello. Yes, in France we have, as you know, a dual system with social security that offers the basis of protection to the whole of the population. And then, as a complement, historically, we have what we call some healthcare packages, additional package, where people can have, and they're adapted to the needs of the population. So it could be individual people that get the insurance, or for us, for our members, it's half of the turnover that is made by individuals, and the other half is made by companies. So this is the collective insurance for those of us who are in a company. Those of the people who are in a company, they benefit from the same coverage for disease and prevention, etc. So that's how it works in our country. In total, we have the rest to pay that is from one of the lowest one, the copay, which is one of the lowest one in the OECD countries. These complementary package are very good for 3 risks because the social security gave them to us to deal with. We reimburse 44% of teeth, dentistry, of also audio system devices, and 66% of glasses and anything that is linked to optical. And we have 100% health with a bunch of different treatments that was completely drafted, like many things in the field of health, by the Ministry of Health. If you sign up in this logic of 100% health, you don't have anything to pay. It's all taken care of. So it's a goal that is constantly updated and we're trying to, as much as we can, to reduce the rest to pay. So what situation are we in today? Are the French people happy with their healthcare system, with their access to care? Not at all. The answer is not at all, because we have 87% of the citizens who live in medical deserts. What does that mean, a medical desert? It's a place where you don't find any doctors. I like the barometer created by AXA and the work stoppages. They study, for example, when people go on sick leave in France. The employees who live in medical deserts, they have less sick leave, short-term sick leave, but they have more long-term sick leave because they're diagnosed later, so they have disease that are more advanced, that are progressed more, and their sick leave is going to last longer. So we see that it has very concrete consequences. It's not just because people don't have access to medical skills, but it's just the numbers prove that it's a real problem. So you talked about our white book. We have worked a lot with all the stakeholders of the health sector, with patients to begin with. The major challenges that we face today is access to care, but also the healthcare journey. So even for those who have access to care, there's a complete inequality in the treatments, that some of them are really complicated and some are easier. And that because it has to comply with the quality standards that are identified by the High Authority of Health in France. The third challenge for us is prevention. I fully agree with what you said, Pierre-Yves. Today, access to prevention is not spread out because our healthcare system was not built that way. It's a system that aims at curing, not at preventing. So we prevent for natural hazards. Whatever the risk is, I can tell you, to convince people to do prevention, they need to have an immediate return. The one immediate result could be the fear of avoiding something worse. So it's like on the road, we can avoid deadly accidents by reducing the speed limits. But if we tell people you'll live longer if you do prevention with your health, it doesn't work. So I get back to this maybe later. If we talk about the solutions, we really need to integrate the person, the patient, and it's not a patient at this point. They're not yet sick when our members need to get prevention. But we need to integrate the fact that to convince them, they need to have a reward, a short-term reward for their investment in time, if not in money, that they make on their prevention insurance. So that's where we're at in France today. To illustrate what Florence LUSTMAN said, there's a pathology that you know well at Novo Nordisk, is obesity. You put onto market 2 drugs that we talked about, Ozempic, one of them. It's an anti-diabetic, and the Vecomi, and it's option for people who are suffering from obesity or overweight. You said obesity is a societal disease, and the access to care is not well anticipated enough by public authorities. So can you explain to us why, and why in this particular case, why we really need prevention? Thank you. First of all, I would like to give you the landscape of Novo Nordisk. We're held by a Danish foundation, and we're a pharmaceutical lab. We've been looking into chronic pathology, diabetes, and more recently, for the last 15 years, obesity. So when we look at the challenges that we're facing, the global challenge is 1.5 billion people who are suffering from obesity in the world. In 15 to 20, we're talking about 4.5 million people. So that means that we're facing a huge challenge for all of us and for the healthcare system, for the insurers, a challenge which is chronic disease. And all the pathologies are getting more and more chronic. When now we develop a cancer, it's not only an acute treatment, it's all this becomes chronic. So the question that is on the table is: are the public authorities and all the reimbursement system, is it all thought in order to with keeping in mind what is anticipated to happen in the next 15 to 20 years? There's a challenge with numbers to begin with. When I tell you 4 billion people, you can tell me, oh, you can live with diabetes or obesity. Well, that leads to many other pathologies that are going to degrade your body. So there's vascular risk. It can be improved. It can be prevented. There's a risk to have kidney failure. The prospects of having a dialysis for the health is hard to put in place. And particularly for the patient, for the person who's affected in the first place, it means that their quality is going to be reduced. So if you look at all the organs that are affected by chronic pathologies of cardiometabolic diseases, it's a big challenge. It's an industrial challenge as well, because we need to generate innovations and with therapeutic visits, and we need to be able to scale up some devices of protection. And production, we have difficulty sometimes to obtain the treatment and the medicine on top of having access to the doctor, and this is a big challenge for us. It's also a challenge for the public authorities, because if we look at the public accounts, even, we have 66% of the spending, health spending, which are focused on about 40% of people, of the population who have chronic diseases. So 40 people, 126 billion. These are big numbers to digest for public spending. And we worked on the obesity part more particularly, and we see that in France, and this is really clear: 12.7 billion for the social security, and 9 billion for the employment and access to employment because of that. So the whole bill is 23 billion. So if we don't do anything, the cost of inaction, if we don't do anything about it, is 24 billion in France. And the question is, can we activate public policies of healthcare that are more efficient? Yes, by integrating more innovation. We're going to talk about the solutions right after. And one of the solutions is to activate prevention and not to be dogmatic on the topic, but to be pragmatic in a way to put in place prevention in all the regions. Dr. VANDINE, the issues that you have in Cambodia are not comparable to those that affect France. The health system in your country, which is still a developing country, and it's really showing a lot of inequalities of access to treatment and medicine, particularly in big cities, and the copay that is up to 60%. So can you explain to us briefly the challenges that you're facing at the moment at the Ministry of Health of Cambodia, and tell us how you are intending at the horizon to 2030 to put in place a coverage, medical coverage that is universal, that you still don't have in your country.
For the floor and the opportunity to speak and to share about the Cambodian healthcare system. As you may know, that Cambodia developed the healthcare system since the scratch. After 1979, we have only less than 50 healthcare professional survival from the Khmer Rouge killing field. Okay? Yeah. So I just give a little bit that you can know. And over the past 2 decades, we have seen the incremental of the life expectancy to 74 years in 2024, up from the 12 years in 1979. And the significant reduction of the maternal mortality rate, infant mortality rate, child mortality rate, and neonatal mortality rate. It's really dramatically increased, as highlighted in the Cambodia Health Demographic Health Survey in 2022. And these improvements are linked to the better immunization as well as the expansion of the healthcare service delivery in Cambodia, including the implementation of the Health Equity Fund and also the National Social Security Fund. And the National Social Security Fund covers the health benefit for the people, and also giving the opportunity for the health services, including the maternity, benefit about 2.7 million people, costing about $574 million annually that the government paid, okay? Yeah, paid. And quality improvement in the health services also include the community engagement and integrating the technology into the implementation of the primary health care booster implementation framework. That the acronym is the PHC-BIF, okay? Yeah. So in line with the royal government of Cambodia vision, we aim to achieve the universal health coverage by 2035. And this universal health coverage target 80% of the population covered by the social health protection, and 80% of the population receive the health services. It means that we expand the health services to cover the population about 80% by 2035. Last but not least is to reduce the out-of-pocket payment to 35% from 60% as estimated or reported in the WHO documentation, but we try to do this comparing to the total expenditure of the population. So we are in the crucial point in accelerating the implementation of the PHC-BIF, because there are two arms. One arm is the improving the health service delivery at the community level, and the other arm is about the encouraging the community participation, including the local community accountability and engagement, which before we have not done that so much yet. But now we are trying to do that. So our PHC-BIF aim for the healthcare improvement and quality, including the access to the rural population, meaning that we think about the people center, equitable, and also they integrated to tackle the risk of the non-communicable disease, which accounted for about 60% of the total deaths in Cambodia. Okay, yeah. So I think despite our progress, but the challenge remains. One, it's the urban-rural disparity, and that continues to impact the healthcare access, and about more than 64% of the total population living in the suburban area. So the access to the rural healthcare facility need the enhancement. And urban centers often have the advanced technology and better facility, while some rural areas lack the basic services, equipment, and trained professionals. Therefore, improving rural health infrastructure, basic equipment, and engaging community will help to bridge this gap. And many health centers in Cambodia meet the national standard. However, upgrade and renovation are still necessary and is underway right now. We are doing that. Learning from the COVID-19 pandemic, building resilient our healthcare system is also crucial, especially in the emergency, control and prevention of the infectious diseases, while expanding care and prevention for NCD. We are strengthening also the public health laboratory and enhancing inter-sectoral coordination, including One Health approach, to create a robust response framework. According to the WHO, as I mentioned earlier, that 60% of the health expenditure come out from the pocket, okay, out of the pocket payment. And Cambodia addressed this by using the scheme such as the Health Equity Fund, and also the free exemption for the poor on the spot, mainly on the healthcare facility, that can help for the poor and vulnerable group. Over 3 million of the Cambodians benefit from this scheme. Another promising step is the expansion of the National Health Security Fund to cover both formal and informal workers, and the rollout of the cash transfer for the pregnant women, including the children under 2. And this is the key initiative that link the social protection and health in Cambodia. But broader integration and scalability remain our priority. Talking about the healthcare workforce, okay? We seen the increasing the number of our healthcare. Over 30,000 professionals from less than, as I said, 50 survival after liberation in 1979. And more than half of them work at the sub-national level, okay? And especially at the health center located in the community. And increasing number of the healthcare workers is essential for us right now. And the ratio in 2024 increased from 20 to 28.8 per 10,000 population. We invest in training, digital innovation, allowance incentive, and capacity development to support our healthcare workers in the remote area. Another point is the strengthening the referral system from the health center to the referral hospital, especially to reduce the challenge for the emergency care, as well as the delay of the maternity care, and especially with the northeast part of the countries. Digital tools enhance the quality of diagnosis access in remote area, while we learn by doing it with an inclusive and straightforward tool. So in conclusion, Cambodia is at a defining moment in its healthcare sector transformation. We are making a steady stride toward universal health coverage by promoting the primary healthcare booster implementation, reforming our healthcare financing, and building a resilient health system, including promoting equitable access for health for all. So thank you very much.
Merci, Docteur. Hadja Idrissa.
Thank you, Dr. Sava. The words carry hope for Cambodia and its population. You were born in West Africa, in Guinea, and your population was close to that, but the situation is disastrous. The counter has no fewer than 6 borders with 6 different states and is at the heart of intense migratory flow that is accelerating the propagation of epidemics. So tell us about how the Guineans, and in particular young people, do to find healthcare when they can. Thank you very much. Good morning, everybody. Good afternoon, everybody. So to talk about the health situation in Guinea, I'm going to go straight to the heart of the matter because, as you've just mentioned, in the name of all of the young Guineans present here today, I can speak for them. In Guinea, unfortunately, we're still complaining about total inaccessibility to health infrastructures. And there are certain health centers that are built by the state Some were also built thanks to aid from international institutions. But here I'm talking about remote villages where the prefecture of the state does not have the means to build health centers, where we don't have more than 2,000 people in a village. So it's practically impossible to build health centers in villages where there are not more than 2,000 inhabitants. So imagine how many villages lack healthcare centers. Imagine how many women get pregnant and don't have access to competent staff for the birth, who die in childbirth and who can't get cesareans. I know I'm talking about Guinea, but when we're talking about access to healthcare, Guinea and France, Guinea and Europe, Guinea and the world are all have a common denominator. We're all human beings. And today, I'm here to talk to you about these situations because, unfortunately, we have learnt about the total disinterest of the United States, their withdrawal from the funds they were using within the scope of US aid. And our countries are faced with a lot of diseases, in particular malaria, AIDS, sexually transmittable diseases. We also have certain diseases where trypanocytia, which 15 or 20% of the Guinean population are affected by. So these millions of victims will be part of the country Africans because it is the African countries that have this the most. So let's speak about Guinea once more. We have a budget from the Ministry of Health. It's not more than 6%. So can a Minister of Health that doesn't have at least 10% of the budget of the National Assembly, how can this ministry meet all of these needs? How can this ministry get medication or screening tools? And when the United States withdraw with sexually transmitted disease, if we don't screen for that, for cancer, for diabetes, all of these diseases, it will become, things will scale up even further and people will die. So this is the situation, especially with regard to medication, because women also are faced with the inaccessibility of contraception. So it's also complex. With the withdrawal of the United Nations, it's becoming more and more complicated, especially with the decrease of public aid from Europe. So the associations, the hospitals, health centers and states are facing many difficulties due to these different foreign policies. We can see the problems of access to healthcare are very different across the world. So whether you're distant or not from universal coverage systems managed by public and private sectors, and also depending on the state element of the questions. Dr. VANDINE, you talked to us about your roadmap for 2035. Could you illustrate a specific point of your battle, in particular your battle against counterfeited medicines, which I think in your country is a real problem?
Question regarding the substandard and falsified medicine. But before talking about that, I would like to talk about the how we can make our healthcare system more effective. Okay? So first, we must strengthen our primary health care. As the foundation to reach the universal health coverage, ensuring the services are people-centered, accessible, and equitable, as I highlighted earlier. These include the investing in health workforce capacity, improving infrastructure, enhancing essential service delivery at the community level. Right now, we are focusing pretty much more on expanding the health services at the tertiary healthcare level, mainly at the community level. So we have like 1,305 health centers. So now we are improving, including health infrastructure services, expanding the services to cover the hypertension and also the diabetes patient before they have to come to the capital, to the provincial town or to the capital city in order to receive the medicine. But right now, they can access the medicine at the community level where it's near to their house. Okay? So that is one to promote the equitable access to healthcare in Cambodia. Second, the effective governance and accountability mechanism are crucial to optimize resource use and ensure quality. This is we strengthen also the accountability not only from the health structure but also the local community and community itself, including the health center management committee and the village health support group, that they are key in achieving the bringing the people from the community to link with the health center. Number three, integrating the digital solution and robust health information system can improve efficiency and decision making. So that right now we are promoting and improving, even looking at introducing learning by doing some or selected digital tools that our primary healthcare facility, they can also adapt, learn by doing at the same time. Number four, it's sustainable health financing. This is, we are implementing and expanding the coverage for the National Social Security Fund and also the Health Equity Fund, plus the fee exemption at the healthcare facility, which only the Health Equity Fund and National Social Security Fund cover up to now 7 million of the total population, comparing to total population of Cambodia, 17 million. We are right now still expanding, okay, work in progress, and hoping by 2035, we are able to reach, as I highlighted, 80% of the population receive that. Number five, strengthening the service delivery require integrated model, focusing on the preventive, promotive, palliative care, including the rehabilitative, and especially for the vulnerable and underserved population. One of the good lesson learned is right now we are working with the local community, try to search for the people who are unable to pay, but they sick, but they are not going to the health center. Then each village, they have to make sure that no one left behind. And now we are doing that. And hoping that by doing together with the local community, then we are able to really helping the vulnerable and the poor population as well. Finally, community engagement and health education is very essential. We should not neglect about that. And it's kind of boosting the knowledge. I may say that health literacy, boosting health literacy of our population, that they can shift their focus from the cure to prevention. That's why right now we are promoting the prevention rather than cure. People often, they said that I don't care about my sickness, I care about my business. If I get sick, I can have my doctor to cure me. If the doctor cannot cure me, it's the problem of the doctor, something like that. But right now we have to shift the way of thinking and promote their better understanding to buy the health prevention rather than treatment, okay? So this is a more effective, the way that we see, so inclusion, a more effective healthcare system built on equity, resilience, efficiency, sustainability principle with leave no one behind. Talking, I have time, right? Talking about the substandard and falsified medicine, because of the time, we can talk about this subject for the whole day, because this is a complex issue, and we need the local, regional, and international collaboration in order to tackle this issue. And I would like to move straight forward to the action that we are doing right now. One is the revised drug law and other related legal documents. Number 2, promote online registration of drugs by improving the Cambodia pharmaceutical registration system and updating the registration procedure and required document. Improve and expand the inspection activity with law enforcement. Strengthen the regional coordination, especially with the bordering country. Build capacity in detecting, reporting, and response. This is very important. And enhance and promote regular conduct of post-marketing inspection. We are doing that a lot right now. Yeah. Share information is very important also. We can share among the region, among from country to country, that we can work together. Enhance quality control capacity in collaboration with WHO Collaborating Center. Last but not least, we have to raise the awareness among the public about the substandard and falsified medicine that they can also report to the Ministry of Health through our hotline system 115, including working together with the custom and other regulatory authority that we can control the border and as well as the substandard and falsified medicine. Thank you very much.
Thank you. Hadja Idrissa, votre ONG Impact Jeunesse fait un gros travail à prendre leur destin.
Saja, you're in Guinea. We want to take advantage of your presence in Aix to launch a call for donations to people in charge of hospitals or clinics, structures related to the world of health that are participating in these rencontres. What do you need? What equipment do you need? And material to transfer things from France to Guinea. Thank you for giving me this opportunity. So why I'm taking advantage of this opportunity to issue this request is because we want the young people want to stay in Guinea. We know what's happening today with migrants. So I'm taking advantage of the opportunity when I speak of the problems that we can find to see if we can find solutions with the help of people with goodwill and health centers and hospitals here. Because as I speak to you in my own village, there is not one hospital bed that will allow women to give birth. And the number of women and young people who've migrated to come to Belgium or France or to the United States. And the first reason is because we don't have any access to health care and certainly not in a fair and equitable way. So we need beds, we need equipment, health kits. If you have access to screening tools, AIDS screening tools, because it's very costly for us, medication, paracetamol, if we can mobilize all of this, we can put it in a container and take it and share it among the villages so that the village girls can use it. Equip the hospitals that have been built by the communities, because most of the hospitals are built by the communities. And therefore, more concretely, I'm launching this appeal to all hospitals and healthcare centres and people of goodwill who were ready to support this type of initiative to save lives in the world. Thank you. Florence LUSTMAN, what can you advise to her? You know a lot of people. So let's come back to France for a moment. Among the obstacles in France, there is health data. You say that the argumentation in France is very constraining on the subject and that patient data is highly protected by the Social Security and that it slows down the transfer of information to private insurers. But technically and legally, is it possible to do better today without betraying the medical secret and the respect of private life, which is owed to the French? So yes, indeed, why do we raise this question? Because we can see that our healthcare system is, running out of breath, and we're talking about the deficit that will exceed 20 million euros for the Social Security in 2025. So the system is no longer sustainable. There are certain things that we can do. I would say that the two main avenues to improvement are innovation on the one side, and, by the way, I always say that thanks to the savings that you trust us with, and this saving is invested in 20% in companies, and in particular in the world of health innovation. So there's innovation on one side and there's prevention on the other. And then there's what we should do and which should be imposed to everybody. It is to fight against fraud, because nobody would be losing. There would be no reduction of reimbursements for anyone. Only the frauders, who sometimes are organized from abroad, And to do this, we must have access to a minimum amount of data concerning the type of care that people ask to be reimbursed. So the frauders, fraud social security, and the health insurances. We've assessed the potential of fraud that we could recover if we had access to a little bit more data. It is 2.7 billion. And of course, for the social security, it's a lot more. So today, I can see a schizophrenia between, on the one hand, this need we have of fighting against fraud, but also medical innovations, which are absolutely extraordinary, and which are almost all based on the use of data. And as we're talking about health, on the other hand, we have GDPR regulations, etc., which forbid the use of this data. Whereas in France, we have health data registers, which are very rich, but we can't access. And when I say health data, it's not medical health data as such. So, for example, the correction of my glasses is data that is not accessible to my health insurer, even though I provide my consent. So beyond this topic of fraud, which is very important because we can see that the amounts are absolutely staggering, I think that there is a big challenge in our country around prevention. Of course, we have to make people want to engage in preventive medicine. And what Pierre-Yves was saying is that it's always the same people who have an appetite for prevention. They're those that have the less risky driving attitudes, and have access to preventive mechanisms. The interest that we can present as health insurers as compared to social security is that we can speak to the people we insure every day if we want. So 96% of the French population is covered by health insurance, complementary health insurance. So it's practically everybody. It's not 100%, but 96%. If we could, through the follow-up of our insurees, those who never go to see the doctor, never go to the dentist, we could send them personal messages. That's the first point, is to find these populations where they are, which for their own reasons, and Pierre-Yves mentioned a certain number of these, but actually don't have any medical consumption. Some overconsume, but others have no consumption. And the second tool, which has proven its efficiency throughout the world, except, of course, in France, because we haven't implemented it, is valid for all risks. And that's what I was saying earlier on. People must have immediate feedback after preventive action. What we suggest is that in the complementary health insurance contracts, that there be a reimbursement bonus for patients who engage in preventive medicine, who respect the recommendations from the High Authority of Health, because unfortunately these recommendations are not necessarily followed by prescribing physicians. So I think we need these two things. We need to have access to data, but we must also make patients, and above all those who are not yet ill, to consider their health as a real personal capital. And as complementary health insurers, we can help them to grow this health capital, their own health capital, so that they can live longer, but above all in better health. You were talking about innovative medication, and we'd like to hear you on this subject. TICHIT, these medications are very costly, at least far more costly than standard treatments. In France, should we revisit the way that these medications are reimbursed and imagine other reimbursement methods than those that exist today? Well, the first thing is that what you're qualifying of costly or not is something that we could debate about in a session. What is important for me is the health value. So the first thing, and I will submit a paradox to you, only innovation is economic. Today, you choose your practitioner, you choose a treatment that is modern, innovative, rather than stacking up old molecules, and you will have a far greater impact on your health. Today, we can prevent cardiovascular risks, heart attacks, vascular accidents. We can prevent the decline of kidneys or fatty liver, and this is something that affects 5 million people. And so today, if we can look after this with one molecule, you can have an impact on practically your entire body. And so this is what we need to look at. It's not really the cost. The question is the health benefit higher than what we've had in the past? So yes, I will come back to this paradox that, might mean something to you. I heard only quality is economic. That's what I was told at the time, a very long time ago when I started out on my career. Today we say only innovation is economic. And on the question that you were mentioning regarding preventive medicine, I think that there's a lot of work to be done on 2 aspects: finance innovation, and on the other hand, to invest in prevention. So it seems simple, but like this, we carry this out into the territory. So we're trying to prototype a prevention option around Strasbourg, the metropolis of Strasbourg, 30 towns with the public authorities. This is a public-private associative approach. We've identified 6 places where we had to intervene. And in these 6 places, we say, what type of intervention should we bring? Is it food banks? Is it with sports health? What do we need to set up in order to prevent diseases? And going to, already talk to young children in schools, and we've intervened so that fruits and vegetables were used in schools. So we tried to prototype inventions that are rooted in the territories and that are co-funded. In Strasbourg, we have 15 or 16 partners. It's an alliance of skills. And in this alliance of skills, we have, once again, the public-private associative world, the health experts in the university hospital. And this is what we must create also. It's the model that we're familiar with in Denmark, because once again, we're a Danish company. And it is this model that we're familiar with in Denmark, where prevention is carried by towns and communes. And this is a capacity of jurisdiction that is important. It's impossible today to imagine a preventive healthcare system that is carried by healthcare players that are not there, not available. And when we talk about medical deserts, that are not in the right place. So it is a jurisdiction in Denmark that has been positioned at the level of the communes. So we could talk, this affects all aspects, not just diabetes and obesity, but we're talking about ergonomy, aging better, the risks of falls. We're looking at global prevention, and the model is in the territories, and that's what we believe in. That's what we're trying to develop for 5 years now in Strasbourg. We have 800 children that come into the program every year, and we will measure the health benefits. We will be able to give you figures to tell you how much we can bring down the plagues of diabetes and obesity. Innovation is key because, once again, innovation carries the hope to prevent other diseases. Obesity gives rise to 18 different diseases. So by treating obesity, you manage 18 other diseases. You prevent them from appearing. You prevent people from having to have dialysis. So this would be a contract that would improve health for everybody. Thank you very much for this broad international panorama. We've traveled far and wide on these health issues. We can take a few very quick, short questions, 1 or 2 maybe. Yes, hello. Thank you for these presentations. I would like to talk about the offensive point of the Trump's American administration around what you said, the de-investment from the WTO, which is devastating, but more practically, the price of medication, drugs in the United States. If they lower the prices of drugs in the States, will it destabilize the systems which allow certain low-revenue companies to access medication at a lower cost? And does the industry have alternative solutions to mitigate this threat, which could be a heavy threat for United States, Europe, and third countries? I'm not going to digress on the subject. It's a very important topic, so thank you. I think that there is one point that concerns all of the pharmaceutical drug industry today, and I think public authorities in all countries should take this on board, in particular in Europe. It's that today the United States fund research. And the question is, how can we in Europe manage to have a united Europe, a Europe around medication and health that can come together around this question? And I think that's the real challenge, and we need to find the keys so that Europe takes the lead once again. We have brains, we have expertise. Our research, when we place it in hospitals, we also fund hospitals by setting up these research programs. So we must work hand in hand to succeed. And in France, we are investing massively. I have 45 people who I've brought in since January 2024 to defend research in France for chronic diseases. So we're working with institutions, and the challenge is to manage to fund research supported in Europe, to have a strong Europe, and to manage to be less dependent on funding of innovation by the United States. So I'm afraid that we have no more time. Thank you very much for your attention. Thank you, ladies and gentlemen.